Thank you very much. Good afternoon. My name is Dr. Ahmed Ali, and I have been working as an assistant professor cardiology in People's University of Medical and Health Sciences, and I have done FCPS cardiology and post fellowship in interventional cardiology from NICVD, and also did MRCP UK. Currently working as IP here in PMC. So we will talk about certain, ECG abnormalities, ECGs, abnormal rhythms, right? So our topic of discussion is today atrial tachyarrhythmias. Okay, so when we talk about the tachyarrhythmias, it means there's a disruption of the heart rate, there's a rise in the heart rate, and there's going to be abnormal, right? As this topic suggests, enhanced atomicity causes three varieties of atrial tachyarrhythmias. One is the accelerated atrial rhythm, second is the proximal atrial tachycardia with block, and third is the multifocal atrial tachycardias, right? Okay, so as I said, the atrial tachyarrhythmias, as the term suggests, the rhythm arises from the atria. As we have been reading out since beginning, the SA node is a pacemaker of the heart that normally constitute the pacing ability of the heart. Why? Because the pacemaker SA node has a more intrinsic capability to discharge at the rate of 60 to 100. That's why it overtakes the paces of pacing activity of the heart, and it paces the heart. Every cardiac myocyte has potential to depolarize. These are the specialized cardiac myocytes. So the conduction system of the heart consists of SA node, AV node, bundle of this, right and left bundle branch block, and left bundle further divided into anterior and posterior fascicles, and these fascicles are further divided into Purkinje fibers, right? So these are the conduction system of the heart. These are called specialized cardiac myocytes. Okay, each cardiac myocyte has potential to depolarize. That's why most of the time you see certain arrhythmias arising from atrias, arising from the ventricles. So we will be talking about the atrial tachyarrhythmias. Sorry. So as the name suggests, atrias. The what is the focus? Atria is the focus. The impulse is coming from the atria, right? So there are the three mechanisms of the arrhythmias, tachyarrhythmias. You would be learning in the future lectures. One is the atomicity, second is the trigger activity, and third is the reentrant. Okay? These are the three mechanisms how the tachyarrhythmias originates. As we talk about certain other disorders, like the patients had previous myocardial infarctions, now presented to you with a ventricular tachycardia. So what is the mechanism of the tachycardia or ventricular tachycardia? That is the reentry circuit formations. Okay, there is a circuit formation around the scarred myocardium. That is a reentry mechanism for the tachyarrhythmias. Certain other clinical conditions, like patient has been on digoxin, there is a digoxin toxicity. The patient may have the atomicity that gives the origin to the atrial tachyarrhythmias, right? And one is the triggered activity. Triggered activity is seen in many other metabolic conditions, like hypokalemia, and giving rise to ventricular tachycardia, atrial fibrillation, and certain other tachyarrhythmias. So we will be learning in the future slides. Okay, so our topic of discussion is atrial tachyarrhythmias. So it is actually enhanced atomicity that causes the atrial tachyarrhythmias. What is the mechanism here? Atomicity. As I said, each cardiac myocyte has potential to depolarize, right? While the conduction system of the heart, these are the specialized myocardial cells. The SA node has a more inherent capability to discharge. Why it passes the heart? As I said, because its heart rate is 60 to 100. And what is the discharge capability of the AV node? That is 40 to 60. Okay, so who is going to master the heart? Who is going to pace the heart? That is SA node, because it has more higher heart rate than the AV node and the rest of the connection system. That's in normal condition. And in physiological condition, SA node passes the heart, right? Okay, so as you know, this tachyarrhythmia further divided into accelerated atrial rhythm, PAT with the block, PAT for the proximal atrial tachycardia with the block, and MAT is the multifocal atrial tachycardia. Okay, try to understand the concept. There are the three varieties. One is the accelerated atrial rhythm. There is a second is the PAT with the block, and third is the MAT. Okay, so normal individuals may have the periods when the lower atrial pacing side may predominate the SA node, producing the accelerated atrial rhythm. Okay, as I said, the SA node is, the master of the conduction system. It passes the heart, but there is a certain time when there maybe the pathological states like the patient's SA node is going to be dysfunctional, or certain other metabolic disorders that causes disruption of the SA node, or any other condition that causes enlargement of the atria, causes the other sides to over dominate the SA node, right? And they produce its own impulse. The morphology of the QRS complex is normal in the presence of the ventricular rate in the range of 60 to 130 minutes, and there are the preceding abnormal P waves. Keep in mind, you must determine the P wave by its morphology. As I always say, the P wave is denoted by its morphology. If there is any change in the morphology of the P wave, it means it's a P wave that is not coming from the SA node. It may come from the atria, it may come from the other sides as well, but it's not coming from the SA node, because SA node P wave is predefined. It has a normal morphology, right? So hence the morphology of the QRS complex is normal, because the ventricles are depolarized from the atrial rhythm. Okay, as we see in patients with the ventricular tachycardia, ventricular rhythm, you see the wide QRS complex, because the ventricles, the origin of the focus lies in the ventricles. But in case of the atrial tachyarrhythmias, the P wave is coming. It's not the normal P wave. Morphology is changed because it's not coming from the SA node. It is coming from the adjacent tissues of the myocardium, atrial myocytes. That's why the morphology is different than that of the SA node P wave, and depolarizes the ventricle and produces the QRS complex. So QRS morphology would be normal. It's not going to be wide or some disruption in the QRS morphology. It is a narrow morphology because the ventricles are excited by the P wave that is coming from the atrias. Though it's not from the SA node, but it's from the yet it's coming from the atrias. So it's a higher up P waves and depolarizes the ventricle and produces a QRS complex. The rate may vary. It may be 60 to 130, and a little bit on the higher side, because we call it the tachyarrhythmia, and atrial tachycardia there is a heart rate longer than in normal resting conditions. Okay, and there are the preceding P waves that are morphologically abnormal. Okay, her QRS is preceded by the P wave, but it has a change morphology. Okay, so PR interval is normal or decreased depending upon the distance of the foci from the SA node. Okay, try to understand this line. Okay, so it says the PR interval is normal or decreased, because you see what is the normal PR interval, that is how much length of the normal PR interval. Yes, 0.1 to 0.2 seconds, right, or 3 to 5 symbolic square. But in case of the atrial tachyarrhythmias, it may be decreased, it may be normal or it may be decreased depending upon where the focus exactly lies. It may lie adjacent to the SA node, it may lie a little bit away from the SA node, because when the focus arises from the adjacent to the SA node, it comes to the SA node, depolarizes the SA node, and then travels down in the AV node, right? So focus primarily lies in the atrial myocytes, but it adjacent the SA node. Okay, and that impulse has to travel to in the SA node, and depolarizes the SA node and produces the abnormal P wave. Why the abnormal P wave? Because originality the impulse has arisen from out of the SA node, and the PR interval depends upon how it is close or distant from the SA node. If it is distant to the SA node, then the PR interval will be larger, lengthened. If the P wave impulse is close to the SA node, then the shorter PR interval. Right? Okay. So here you see this is the ECG depicting the atrial accelerated atrial rhythm. Just try to concentrate on the arrow showing the P waves and QRS morphology. How would you interpret this? You see, what is this? What is the arrow indicates? Oh, sorry. Okay, so yeah, what is this arrow indicates? This is a P wave. Okay, inverted P wave, right? And what is the morphology of the QRS complex? What is the morphology? Is a narrow QRS complex. Broadly we categorize the QRS complex whether is a narrow QRS complex or the wide QRS complex. Narrow QRS complex by definition is lesser than the 0.12 seconds, or less than 3 symbolic stars. That is the normal morphology of the QRS complex. That is a narrow QRS complex. But in certain states, as we see in the tachyarrhythmia like ventricular tachycardia, ACT, the bundle branch block, certain other electrolyte imbalance, hyperkalemia, ventricular rhythm, idioventricular rhythm, many conditions can cause wide QRS complex that is more than 3 symbolic stars or more than 0.12 seconds. So here you see the narrow QRS complex with the inverted P waves preceded by the QRS complex, right? So what you would derive from this ECG tracing? How would you interpret it? You would say that there is the atrial rhythm actually. It's not coming from the SA node. It's coming from the atria. That's why the P wave morphology change. You see, it's a low atrial rhythm. Why we call it the low atrial rhythm? Because the SA node that is depolarizing the heart. It is the atrial myocytes that is depolarizing the heart, and that's why the P wave is produced. That's quite different in morphology, right? You understand my point? The Q wave is inverted here. That's why we call it the atrial rhythm, but the QRS complex is narrow because the ventricles are depolarized from that P wave that is coming from the atria. Okay, so this is the ECG depicting the atrial tachyarrhythmias. Okay, this was called accelerated atrial rhythm. Why we call it accelerated? Because the heart rate was little bit on the higher side. Okay, it was in the range of 120 to 130. Hence we call the accelerated atrial rhythm. Okay, this is one of the variety of the atrial tachyarrhythmias. You would have such sort of the ECG sometime you see in patients. So what is the mechanism of the arrhythmia here? Atomicity. Atomicity I mean every cardiac myocyte has a potential to depolarize as some underlying clinical conditions. Okay, so second variety of the atrial tachyarrhythmia is PATE, paroxysmal atrial tachyarrhythmia. Okay, so as the name suggests, there is a paroxysmal. There is a sudden onset and sudden terminations. The brief event is called the paroxysmal atrial tachycardia. The term paroxysmal is actually inaccurate with regard to the PATE with the block because it implies the sudden onset and termination of the cardiac rhythm. Okay, it is a sudden onset and sudden termination of the rhythm. That is called PATE, paroxysmal atrial tachycardia. Paroxysmal, you might have studied for the other terms like paroxysmal atrial fibrillation, paroxysmal ventricular tachycardia. That is actually the sudden onset and sudden termination. By definition, paroxysm defined as a sudden onset and sudden termination. Okay, so PATE actually the digitalis toxicity is the most common cause. Okay, so most of the time you have been working in the cardiology ward, the patient has been on digoxin for the different reasons, like the patients with cardiomyopathy, the patient with atrial fibrillation, and other certain states we put the patient over the digoxin toxicity. They come up laid up in emergency department with the effects of the digoxin toxicity. They may have a rise in the heart rate, they may have some gastrointestinal symptoms, they may have some ECG features. You suspect the patient have digoxin toxicity. So PATE, one of the commonest reasons for the PATE is the patient has developed digitalis toxicity. So why the digitalis toxicity causes PATE? Here it's explained because the digoxin has a parasympathetic effect on the AV node and SA node, resulting in the slow sinus rate. Okay, why we start digoxin a patient with the cardiomyopathy or atrial fibrillation? Because it decreases the heart rate. It acts upon the SA node and AV node, and hence it decreases the heart rate because the conduction is done through the AV node and SA node. So it primarily reduces the heart rate in patients with atrial fibrillations. While at the same time